நம்ம சொல்லுங்க. ஹலோ ஹலோ, நான் கிளாஸ்ல இருக்கேன். பேரை கூப்பிட்டேன். Do you see the slides?
Sir.
Yes, sir.
Yes, sir.
Yes, sir.
The slide moving?
Yes, sir. Moving.
Okay, fine. I think only 15, 17 people have joined. Okay, we will start. So, salutations to my guru, Dr. Chennaiappan sir. This is the statutory advice to you. Please stop me whenever I am not clear. We have covered up to the QRS, isn't it? We have covered up to the QRS. We have told you about the amplitude, importance of the amplitude, not more than 26 millimeter. Anything more than 26 millimeter suggests a chamber ventricular enlargement. And width is more important. If it occupies more, if it is a wide QRS, occupying more than 2 small squares or maximum 3 small squares, we call it as a wide QRS. Any wide QRS confirms that there is a block in the conduction system. Somewhere in the conduction system, there is a block. Up to this, we have seen. Now, after the QRS, we will move to the next segment after the QRS, that is the ST segment. And you all know what is the ST segment. QRS is ventricular depolarization. T wave is ventricular repolarization. But between the depolarization and the repolarization, there is a small time gap. You all know why it is happening, because the depolarization is going in one direction, repolarization is returning in the other direction. So there is a small time delay that is many myocardial cells happen. That small delay is represented in the ECG as the ST segment. So ST segment is the end of depolarization, is the time gap, small time gap between the end of depolarization and the beginning of repolarization. That's a very, very crucial segment. That's the most important segment of the ECG. Than P, Q, R, S, anything, this ST segment is the most crucial segment. This is the ST segment from the end of the QRS, that is the end of depolarization, to the beginning of the repolarization. This segment is called the ST segment. So it is a segment, not a wave, right? So it's, as I told you, this is the most crucial segment, important segment in the understanding of the ECG. Please understand, it is a wave. It is not a wave. It is just a line joining the Q wave and the QRS and the T wave. Just a segment which joins the QRS and the T wave. So it is a flat line only. It has no specific measurements. There is no height. Obviously, it is a flat line. And PR segment, we had a interval duration. It has to be within the time. Whereas in the ST segment, the duration of the ST segment is also not a big matter. We don't calculate. Then what else is important? If it's not height, not width, then what is the significance of ST segment is? It is the shape and the configuration of the ST segment. The most important. How the ST segment is what is more important. See, classically, your ST segment should be like this. So what are the characters of ST segment? There is a imperceptible smooth merger of the S wave and the T wave. See that there is a S wave here. The T wave is here. The S wave and the T wave smoothly merges with each other. We don't know where the T wave, S wave is ending, and we don't know where the S wave is beginning. There is a smooth, imperceptible merger of the S wave and the T wave. The second point is a gentle concavity facing up. See the gentle concavity, small concavity. It is not a straight line. It is a gentle concavity, and the concavity should face up, facing up. That's very, very important. This loss of concavity itself is a significant pathology in ECG. So, gentle concavity facing up. Third is not hugging the baseline for more than 3 millimeters, like this. No, I told you the picture like this. It should not be like this actually. It should not stay. See, it comes to the baseline, stay in the baseline, then take off. That is abnormal. Horizontality of the ST segment. That is also abnormal. It should just like the takeoff. S wave should go to the T wave, that straight away. It should not stay in the midline. Yes, it can stay, but not more than 4 small squares. If any of those things are there, it's an abnormal rate. So it's an imperceptible, smooth merger of the S wave and the T wave, gentle concavity facing up, this concavity, and not hugging the baseline for more than 3 minutes. What is the baseline? It is the PR segment. We take the PR segment as the baseline. This is the baseline. This is the normal shape and configuration of the ST segment. Please remember, any alteration, anything which is not fitting in with this ST segment configuration is pathology. Any alteration, any elevation, or any depression in this ST segment represents an acute coronary syndrome. What do we mean by acute? It is an emergency. It is an emergency. This patient needs to be admitted and treated. Otherwise, this fellow has a possibility of dying next minute or next 1 hour. So the ST segment should exactly be like this only, and anything other than this type shape ST segment is the most important word you should use whenever you see a ST segment abnormality is acute. Acute. Acute means it has happened now, recently, within 1 hour or 2 hours, like that. It is an acute event, and it is always an emergency. It is called the acute coronary syndrome, right? See here, normally your ST segment should be like this. It's imperceptible merger of the S wave and the T wave with a gentle concavity facing up, not in the midline, staying in the midline for more than 3 or 4 millimeters. That is 3 or 4 small squares. That is the normal configuration of S wave. See this S wave, see this ST segment. Do you think it is normal or abnormal? I would like you to be interactive, please. Do you think it is
No,
normal
sir.
or abnormal? What is abnormality? ST?
Depression.
It is depression. This is the baseline. It is coming down. It is a ST depression. It is acute or chronic? It is acute. Is it an emergency? Will you admit the patient or send the patient home?
Admissions.
You have to admit the patient. You should not send the patient home. It is an acute event. You have to admit the patient. See this ST, or is it a normal ST segment? Compare this ST. It is a significant ST depression. A significant ST depression. This is an acute event. This patient has to be admitted. See this ST segment. Do you think this ST segment is normal or abnormal? See, grossly elevated, concavity, upright, everything is there. That's not the matter. But elevation from the baseline, more than 2 small squares, is a pathology. He has to be admitted. It is an emergency. He may die within 1 hour. 1 hour. This is an acute event. See this ST segment. Do you think this ST segment is normal or abnormal? Concentrate on the ST segment. Don't look at other things.
No concavity, sir.
Huh?
Concavity is not there, but elevated.
Excellent, superb. There is no concavity. Otherwise, it looks so normal. Q, RST, everything looks normal. What is not there? The gentle concavity is not there. Loss of concavity itself is a pathology. That is the earliest evidence of a myocardial infarction. We will teach you about it when I talk to you about the coronary artery disease. Infarction teach I will tell you. But please understand, the simple loss of concavity, or we just calling out as a straightening of the ST segment, or ironing out of the ST segment, as if somebody has put iron box and has ironed the ST segment so that it is made flat. So even the small ST a loss of this concavity is a pathology, is an acute event, this fellow has to be admitted. The ECG after 1 hour will be like this. Before this, it will be like this only. So it is a very early evidence of acute coronary syndrome. It is an acute event. See this ST segment. Do you think this is normal or abnormal?
Normal.
Unfortunately, there is no graph here, but see this pattern. See this pattern.
Here also concavity is lost.
Not more than 2 square.
Concavity is lost. Very good. Concavity is there. This concavity is there. What is that? It is a horizontal. It is staying in the midline for a significant distance. If you have the ECG paper there, maybe it is 4 to 5 small squares. See, horizontality of the ST segment is an acute event, is an emergency. This patient has to be done. This looks so normal. Many people will mistake it as a normal ECG. But what is the problem? Horizontality of this ST segment. So, any ST segment, there should be imperceptible merger of the S wave and the T wave, gentle concavity up, not in the midline. They're not horizontally staying in the midline for more than 3 or 4 small squares. If any of those things are there, it is an acute event. It is an emergency. Something has happened just now. That's what we mean by acute. And this fellow needs to be admitted, observed, serial ECG is taken, take all preventive measures to treat him for acute myocardial infarction. Everybody got it? Anybody?
So we can take it as losing concavity is the earliest stage.
Yes, sir. That's the earliest, which is missed by everyone, many people. Which is missed by everyone. That is what I don't want to do. Every one of our students, family medicine student, should not miss this. If you identify this, you will not only save his life, you will also save the myocardium before dying. He will not develop a Q wave at all. He will be a totally normal person after your treatment. Understand? So this is very crucial. This is crucial. This is crucial. This is what many times we miss. Everybody will diagnose this. Everybody will diagnose this. Everybody will diagnose this. But this and this are the very early evidence of ST elevation and ST depression. Don't miss. Remember this pattern, register this pattern in your brain. And if you see this pattern, it is an emergency. Please remember. Okay? Right. So this point is called the J point. See the point where the S wave and the ST segment meet is called the J point. We call it as a J point elevation or J point depression also. Both are that. J point. This point is called the J point. Just remember this. We will have the implication later. Just remember this, right? Now tell me, concentrate on the ST segment. Do you think this ECG is normal or abnormal?
Abnormal.
What is the abnormality? What is the abnormality?
Elevated, sir.
ST depression.
Yes, ST depression.
ST is depressed in beat 1, 2.
There is a significant ST depression.
B4 to B6.
Okay, very good. It is an acute event or a chronic event?
Acute event.
Is it an emergency? Is it an emergency? Will you admit the patient or send the patient home?
Yes, sir. Emergency. Admit the patient.
Excellent, excellent. Which leads are there? Which leads it is there? ST depression.
Lead 1, lead 2.
Sir, it's inferior leads and also antro not there, lateral leads.
Lateral. Excellent, excellent. So which artery is likely to be the culprit? Which artery supplies the lateral leads?
Both two arteries.
Yeah?
Lateral circumflex.
Left circumflex.
Circumflex
LCX artery. So with this information, you got yeah, it is LCX lesion. Excellent. Okay. There is a caveat here. I will tell you subsequently.
Sir, but what about in AVR, sir?
AVR is a reciprocal elevation, doctor. We will tell you about it. What is the reciprocal depression elevation and when we deal with the myocardial infarction. Good. You have made, all of you have made very good observations. What is this ECG? Is it normal or abnormal? What is the abnormality? Emergency or not? Admit or not? Where is the lesion? Which coronary artery is supplying? Which coronary artery is diseased?
Elevation in 2, 3 and
elevation. Yes. It shows hyperacute inferior wall.
Excellent.
Hyperacute inferior wall MI with some lateral wall changes.
V5 இது just clicks கொடுக்கல நாங்க. We have given only
I
the
mean,
inputs. Okay. So it is an inferior wall, ST elevation, myocardial infarction.
reciprocal changes in the 1 and AVL are there.
Very good, very good.
Reciprocal
So
changes.
do you think it is a red thrombus or a white thrombus? I told you in the class. Pathophysiology coronary disease, I told you in the direct class. Do you think it is the occlusion has led to red thrombus or a white thrombus? ST elevation is always red
Appears
thrombus.
to be a red.
ST
Red
depression
thrombus,
is
sir.
white thrombus. ST elevation is red thrombus. ST depression is white thrombus. So what will you give? Antiplatelet or fibrinolytic therapy?
Fibrinolytic.
Yes, this patient requires a fibrinolytic therapy. Super. Excellent. Which coronary artery is applying? Which coronary artery is diseased now?
Posterior.
Posterior.
Posterior no artery. We have
Right
right coronary artery.
Right.
This right coronary artery.
Posterior descending.
Yeah, inferior wall is supplied by the right coronary artery predominantly. Occasionally, it will be supplied by the left circumflex, depending upon the dominance of the system. If it is a right coronary dominant, it is the right coronary which will supply the inferior posterior wall. If it is a left coronary dominant, left circumflex artery will supply the inferior posterior wall, right? Okay, very good. Super. Comment on this ECG.
This appears to be a resolving inferior wall MI, sir, because there is a tall R wave into 3 AVF and the ST elevation is getting reduced to baseline.
We don't know. We
And
don't know. 1 hour
reciprocal
later, it may also
changes in
increase.
AV.
Yeah. Okay, good. Everybody
Yes.
agrees and you are able to pick up this ST elevation. Anyone is doubtful about the ST elevation here? Anyone here? Shall I take it as no one?
Sir, there is no
The ST elevation, what is the baseline? Your PR segment is the baseline. This is the baseline. See, this is the baseline. From the baseline, this is called the J point. Is the J point elevated above the baseline or is it on the baseline or is it depressed from the baseline?
Elevated.
Everybody is able to identify this elevation?
Yes, sir.
Yes, sir. Yes, sir. Yes, sir. I want
Yes,
17 yes, sirs.
Yes, sir.
17 people are
Yes,
there.
sir.
Yes. So correct. So this is a ST elevation. Super. As somebody picked up last time, there is also some ST elevation, but there is a reciprocal change. We will come to that later. Whenever there is ST depression and ST elevation is the primary event. Right? Take it that way. We will
Sir,
tell
in
you.
which leads we have to see ST?
Which? What did you say?
So in which leads we are seeing only 2 and 3, sir?
Yeah, 2,
1,
3
2,
and
3.
AVF.
Yes,
Lead
sir.
2, lead 3 and AVF. I told
Okay.
you when I was talking to you about the leads orientation, lead 2, 3 AVF represent the inferior wall. Lead 2, lead 3. You have to look for ST changes in all the 12 leads. Then
Yes,
say which leads have that. Then that should correspond to a particular coronary artery territory. I told you lead 2, lead 3 AVF represent inferior wall and that represent right coronary territory. Lead 1 and AVL, V5 and V6 represent the superior and high lateral surface of the heart supplied by the left circumflex artery. Your V2, V3 and V4 supply this represent the anteroseptum. Anteroseptum supplied by the left anterior descending artery. Left anterior iliac. Right? Remember these things. You will remember over a period of time. Right? Don't worry. If you keep seeing, you will understand it. So that is about the ST segment. Any doubt in the ST segment, none of you should miss the ST segment abnormality. Please. Okay?
yes, sir.
Okay. We will move to the next wave. That is the T wave. It is not this T, it is T wave in the ECG. Right? So T wave represents, you all know, ventricular repolarization. QRS represents ventricular depolarization T wave represents ventricular repolarization. That is, the impulse leaves the cell. That is what we mean by repolarization. Okay. So T wave, how do you measure the T wave? From the beginning to the end of the wave. ST segment over, T wave starts, locate, identify this point, and to the end of this one. Excuse me for a minute. Hello, Soloma. பண்ணுங்க. சரிம்மா அதை அப்படியே ஃபாலோ பண்ணி. I'm so sorry. So how do you measure this? From the beginning of the end to the beginning to the end of the T wave is how you measure. So this is a wave. So it has two dimensions. One is the height, another is the width. Just like for the QRS height and width, you have this wave, you have the height and the width. The amplitude, this amplitude is the height of the T wave, correlates with the amplitude of the QRS. That is, if your QRS is very tall, your T wave also will be very tall. If the QRS is very small, your T wave also will be small. That is why the amplitude go with the QRS amplitude, right? That is the one thing. Second is, but there should be a limit. It cannot shoot too much. Normally 40%, maximum 40%, upper limit is 40%, lower limit is 20%. So your T wave amplitude should be 20 to 40% of the QRS wave. For example, if the QRS amplitude is 10 millimeters, then your T wave, normal T wave is expected to be 2 to 4 millimeters. That is what it means. 20 to 40% of the corresponding QRS wave, right? And width, again, depends upon the QRS. So everything goes with the QRS. The height goes with the QRS, height of the T wave. The width of the T wave also goes with the QRS. If you have a wide QRS, the T wave also will be wide. If you have a narrow QRS, your T wave also will be narrow. So we don't give much of importance for that, except in certain situations. But what is more important is, it should take the direction of the preceding organ. That is the direction, not the height or the, we are not talking about it. The direction. That is, your QRS is positive here. Positive, isn't it? The QRS is positive. Then the T wave also should be positive. If your QRS is negative, your T wave also should be negative. If your QRS is positive and the T wave is negative, that is an abnormality. If the QRS is negative and the T wave is positive, that is an abnormality. Could be a disease. I am careful in saying this word. It is an abnormality. May represent a disease, may not represent a disease. Right? Understand this. Okay. So the importance of the T wave is the direction it takes. Number one, sometimes we have to give attachment to the height of the also. We will learn about it in coronary artery disease. Right? Okay. So this is what it should take, the direction. Q wave and the T wave should take the same direction. So if the QRS is upright and the T wave is negative down, it is an abnormal T wave. Same way, if the QRS is negative and the T wave is upright, that is again an abnormal T wave. Small QRS is small, but the T wave is very big, taller than the QRS itself. It is an abnormal T wave. If it is a very big QRS with a very small T wave, unidentified very small T wave, it is also an abnormal T wave. We call it as abnormal because it is not normal, but it need not represent a disease. There are a lot of other physiological conditions, non-diseased pathological conditions also can cause these small changes. So it is an abnormality. Then it is our responsibility to go in, dig in, and find out whether it is due to a disease or just a part of a normal variation. We can't do that. We will learn it subsequently, right? So please understand, what you have to understand is the direction of the T wave is more important. Concentrate on the T wave now. Do you think this T wave is normal or abnormal? See this T wave, this is the T wave, this is the T wave, this is the T wave. This T wave is normal T wave or abnormal?
Abnormal.
What is the abnormality?
Opposite direction.
It is opposite to the direction of the QRS.
Opposite direction of the R wave.
Correct. Opposite to the direction of the R wave. Very good. So it is a disease. We will see what it is later, subsequently. In the next two classes, understand this. Okay. So clinical abnormality implication is all T-wave abnormalities are non-pathological. That is what I said. It is need not be a disease. It could be a normal variation also. Several non-cardiac conditions can cause T-wave configuration abnormality. Right? So it can cause T-wave abnormality. Coronary artery disease is one of the 1,000 causes. There are 1,000 causes for a T-wave abnormality. Not all T-wave abnormalities are coronary artery disease. Coronary artery disease is one of the many causes. That's the clear idea you have to get. Don't brand somebody just because somebody has a small T-wave version. You should not brand him as a coronary artery disease and treat him for coronary artery disease, right? You have to identify whether it is a pathology or a physiological variation. That's about the T wave. Everybody got it? T wave? Any doubts?
Yes, sir.
Any doubts? Very good. QT. Then after the T wave, what next? What is the importance is the distance between the Q wave and the T wave. That is called the QT interval. So how do you measure the QT interval? From the beginning of the Q wave, that is the depolarization, to the end of repolarization. That is, from the beginning of the Q wave, this is the Q wave, no? This is the Q wave, R wave, S wave, ST segment, T wave. So how do you measure QT interval from beginning to the beginning of the Q to the end of T wave? Up entire distance horizontally is called the QT interval. That is, what does it tell you? How much time it takes for the ventricular depolarization and repolarization. How much time it takes. That is what it tells us. QT interval tells us that. Okay. QT interval, that is what it told you, from the beginning of the Q to the end of the T wave. But the problem with the QT interval is it will change with the rate. For example, if somebody has a tachycardia, you have one QRS T immediately followed by another QRS T, followed by another QRS T. The ECG will be packed with so many QRS Ts, you know. So when it is like that, when it is packed, when there is a tachycardia, the QRS, the QT interval will change. Similarly, if there is a bradycardia, one QRS after a long gap, another QRS, again the QT interval will change. So the QT interval will vary with the rate. So it has to be corrected to the rate. For this rate, what is the QT interval? For this tachycardia, what is the QT interval? For this bradycardia, what is the QT interval? So it has to be corrected by a formula called the BASICS formula. You need not remember all those things. It's a complicated. It's a measured QT divided by R root of RR interval. You need not worry about it. Every ECG machine will give this. If you see a calculation column, it will give you the QT as well as QTC. What is this C represent? Corrected to rate. QTC is direct measurement from beginning of Q to the end of T. When you apply the correction factor corrected to the rate, we call it as a QTC. So look for the QTC and not plain QT. Always it should be correct to the rate. QTC, right? Normal QTC is 0.45 seconds or 45 milliseconds. 0.45 seconds, right? Approximately, it should be half of RR. That is, you take one R wave, next R wave, the QT interval should be, T wave should end within the half of one RR interval. I'll show you ECGs like that. Remember 0.45, right? So what are the clinical implications? If your QT is more prolonged, if the QT is prolonged more than 0.45, we call it as a long QTC. So what are the long causes for the long QTC? Could be a congenital long QT syndrome. Many drugs, your prokinetic drugs, your macrolide drugs have the tendency, many psychiatric drugs can prolong your QTC. Drugs, severe bradycardia, some poisons, electrolyte disturbances like calcium disturbances can cause QT, prolong the QT and give a long QT syndrome. That is more than 0.45 seconds. Suppose the QT is short, very short, less than 0.35, less than 0.35. or 350 milliseconds. 0.35, then you should suspect a digoxin effect. You should suspect a hypercalcemia, or it will happen in a tachycardia. So remember these two things. So somebody should have a normal QTC around 0.45. Anything more than 0.550, you call it as a long QT syndrome. It could be due to congenital drugs, poisons, electrolyte disturbances. It's a important thing. Similarly, if somebody has a very short QT, you should suspect a digoxin effect or toxicity, very low calcium, or it could be due to a severe tachycardia. So, what is the clinical? By knowing this, where do we apply? Always see QT interval whenever the patient comes with a syncope. Whenever I told you, I talked to you about the syncope, somebody faints. Even I think I mentioned that many children are brought by the parents that he fainted during the prayer or fainted in the classroom. We think when he comes to you, he will be totally normal boy. No difference. Everything will be normal. Your pulse, BP, sugar, everything will be normal. We think it is psychogenic, or we think that it could be a vagal attack, and just say nothing, go ahead, nothing. Give him a tonic and send him. All of us do that. But what you should do at least once is whenever somebody, a child especially, comes with a syncope, please do an ECG. And when you do an ECG, don't concentrate on the ST segment. He will not have a ST segment abnormality. Concentrate on the QT interval. If they have either a QT, long QT or short QT, either a congenital long QT or congenital short QT syndrome, then these people are highly prone for arrhythmias. He had a fainting syncope due to some arrhythmia only. It is due to an arrhythmia, and that single arrhythmia could be fatal. Somebody can have a sudden cardiac death. That is the risk. So, if somebody has a long QT syndrome, you should always interrogate that why he has a long QT syndrome, find out the cause, and see if you have any correctable cause and correct it. Otherwise, this person has a risk of a major arrhythmia, or it could be a minor arrhythmia. Sometimes the arrhythmia could be fatal. Please remember this. Dangerous complication is a tachycardia, or torsade epitis is a form of a ventricular tachycardia. So that is why, especially children, please take this message home. Children with the syncope, please do ECG, and when you do an ECG, look for the prolonged QTC. Right. See, this is the normal QTC. See, how do you measure the QT from the beginning of the P wave, beginning of the Q wave to the end of the T wave, this distance. Just keep it in mind. See this 0.41. Normal measured QTC is 0.41. 0.45 is normal. So it is a normal QT. Remember, register this pattern. What do you think this QT? Is it a normal QT like this or abnormal?
Prolonged, sir.
Prolonged. See that? Prolonged QT syndrome. See, the QTC is 0.52. The machine will give you the calculation. Don't worry. You need not do the BASICS formula and the machine will give you the calculation. Just look at it. Many times it will be correct. So QT, prolonged QT. So the commonest cause for a prolonged QT is hypocalcemia. And as I told you, some other drugs, poisons, all those things I told you. See this QT. Compare this and this. Do you think it's a normal QT or abnormal QT?
Yeah, no. Reduced.
It's a short
Reduced.
QT, isn't it? Very short QT. We call this as a long QT. We call this as a short QT. See the 0.36 only. Short QT is again hypercalcemia. So calcium metabolism directly affects the QT interval. If you have a normal calcium level, you will have a normal QTC. If you have a hypocalcemia, you will have a prolonged QTC. If you have a hypercalcemia, you will have a short QTC. You need not do a serum calcium measurement. You can confirm from the ECG itself that he has got a high calcium level or low calcium level. Right? So that is the implication. Right? Any doubts in the T wave, U wave? I'm sorry, the QT interval?
No, sir.
Yes.
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 Okay. The next wave is the U wave. So sorry, Solomon. Hmm. புரியல என்னது? பிளட் எத்தனை ஹவர்ஸ்ல போடணுங்கிறியா? அவருக்கு வந்து கார்டியாக் ஸ்டேட்டஸ் நல்லா தான் இருக்கு. பட் ரொம்ப ஃபாஸ்ட்டாக ரேப்பிடாக போடாதீங்க. ஒரு 75 ml per hourல போடும். பரவாயில்ல பரவாயில்ல. பிளட் வாங்கிட்டு வந்துட்டீங்கன்னா ஸ்டோர் பண்ண முடியாது. போட்டுடணும். நைட்டை போட்டுறோம். கேர்ஃபுல்லாக ஆல்பம்னும் போட்டு பிளட்டும் போட்டிங்கன்னா லேசிக்ஸ் ஒன்று கொடுங்க. வால்யூம் ஓவர்லோட் ஆகிடும். சரி, ஓகே. நான் கிளாஸில் இருக்கேன். அதான் 10 மணிக்கு மேலே கூப்பிட்டு. ஓகே. So sorry, sir. They've been calling repeatedly. I'm trying to silence. So, okay. Next wave is U wave. I have not told you about the U wave much about it. What is the U wave is? It is a small positive wave which comes after the T wave. We say PQRST. After that, there will be a small positive deflection for many people, not for all people. That wave is called the TU wave. That represents the repolarization of Purkinje fibers and papillary muscles. This U wave is like T wave. It also depends upon the amplitude and direction of the T wave. If the T wave is upright, your U wave will also be upright. If your T wave is small, your U wave will also be small. If the T wave is big, the U wave also will be big. It goes with the T wave, right? Best leads are V2, V3 and V4 are the best leads. Look at the U wave. See, this is the T wave. After the T wave, before the next P wave, we will find a small positive wave that is called the U wave. See here, U wave. This is the T wave. After that, there is a U wave. The U wave should be like this only. It should be in the same direction like T wave, and it should be smaller than the T wave. It should be smaller than the T wave. See this here. This is the T wave. This is the U wave. This is the T wave. This is the U wave. Do you think it's a normal T wave or a U wave or abnormal U wave?
Abnormal.
We call it as a very prominent U wave. Very prominent U wave, which is a sign of hypokalemia. Hypokalemia. So how do you diagnose hypokalemia from the ECG? Very well seen U wave, prominent U wave. Any prominent U wave need not be bigger than T wave. Any very well seen U wave. Normally, it will be difficult to see the U wave. A very well seen, nicely seen U wave is a prominent U wave, and that should suggest a possibility of a hypokalemia for such patients. We'll show some ECGs. See, your normal U wave, V3, V4, V5 are the best. V2, chest leads. These 2-3 leads only will show the U wave nicely. See the QRS, T. After that, there is a small positive deflection before the next P wave. This small, that's all it will look. It will be a very small positive deflection. So it is a very small positive deflection. That's all it will look like. So that is a normal U wave. Everybody got it? Everybody is able to appreciate the small U wave here? Small
Yes.
U wave here? Yes?
sir.
Okay. Do you see any other abnormality here?
There is a tall T wave, sir.
There's a
Tall
tall
T
T wave. Is the T wave normal or abnormal?
It's
Abnormal,
abnormal.
sir.
Abnormal, isn't it? It is opposite to the
Different
direction of the
direction of the
QRS.
QR.
Yes, the
Different
QRS
direction.
is negative, T wave is upright. So it is an abnormal T wave. Right? Very good, super. So this ECG is for you to concentrate on the U wave, small U wave. After the T wave is a normal thing. Right. See this. This is T wave, this is U wave. This is T
Abnormal.
wave, U wave. So what do you think? This U wave is normal or abnormal?
Abnormal.
Abnormal.
Abnormal. So what do you call it as?
Hypokalemia.
Prominent U wave. What is the diagnosis?
Hypokalemia.
Hypokalemia is a strong possibility. Hypokalemia is a very good. So excellent. So hypokalemia is a strong possibility. See this U wave. This is the T wave. This is the U wave. Do you think it's a normal U wave or abnormal U wave?
Normal, sir.
Normal.
Opposite
What is the abnormality?
Opposite
It's opposite of T wave.
It is opposite to the direction of the T wave, isn't it? T wave is upright, but U wave is down. This should give a suspicion of a coronary heart disease for him. So this is a very, very subtle sign of a coronary artery disease for somebody. So this will be many times missed. These are all small, small things. As a good family physician who has undergone this course, you should pick up this U wave abnormality, inverted U. We call it as the inverted U wave. Inverted U wave is a sign of coronary artery disease. Okay, right. So small t and large u is pathological. It could be hypokalemia. Upright t and inverted u suggest coronary artery disease. Sometimes it could be a simple volume overload status, but it is abnormal. It is pathological. You have to investigate him further. Right. Okay. So we have completed all the waves. P, Q, R, S, T, U. Every wave we have seen. Okay. Let's see how much you remember. You know, overall, you have to look at P, Q, R, S, T, everything. See this ECG. Do you see any abnormality in this ECG? Look at
He
everything.
is a bit
All
tall.
the waves. Huh?
He is a bit tall, sir.
Very good. Super. P is a tall P wave. Look at here. Definitely more than two small spaces. And it's a big tall P wave. Everybody has picked it up?
Yes, sir.
Yes. What are the diagnosis here?
Tall
Atrial enlargement, right atrial enlargement.
Right atrial enlargement. Excellent. This is suggestive of a right atrial enlargement. Very good. See this P wave. Very tall. No, this is QRS. See the P wave. Is it normal? Definitely it is not a normal P wave. Normal P wave should be like this. It's a very tall P wave, suggesting right atrial enlargement. Very good. Right. Comment on this. Just one point about in ECG. Normal ECG or abnormal ECG?
Abnormal.
Where is the abnormality?
There's a U wave amplitude and
ST
duration. Both
elevation
are,
and U wave depression.
ST elevation.
ST elevation.
Concavity is lost.
no. The Q in V1, V2, V3, 4,
Okay.
V5.
Okay.
The duration is long and the amplitude also is high.
Which one? QRS.
QRS, yes, sir.
Is it a narrow QRS or wide QRS?
It's a wide QRS.
So wide QRS. So what is there? What is the disease? What problem he has?
Ventricular.
Wide
There is a delay,
QRS.
sir.
Wide QRS.
It's like having
Conduction block, sir.
Conduction block. Excellent. It is a conduction block. Somewhere the block is there. It is a right bundle, left bundle, all those things are there. You will learn it. Next 2-3 classes, you will know, you will diagnose where is the block. Today, as of now, it is a block, conduction block. Everybody is able to appreciate this, white QRS.
Yes, sir.
Yes, sir.
White QRS, conduction block. There are some subtle ST elevations in depressions, agreed, but it will be there in bundle branch blocks, right? We will learn it later. Fine. So, comment on this ECG. Concentrate on P wave, PR interval, QRS, everything.
The PR interval is short because there is
Super.
nothing of the
Excellent. Very good. PR interval is so short. See the PR interval. Almost no PR segment at all. The P wave immediately followed by a QRS. Short PR interval. So what is your interpretation?
WPW syndrome.
Superb. Excellent. It's a WPW. Everybody, sir? Everybody?
Yes, sir.
I want everyone to recognize this. It's a WPW syndrome. Good. What is this? Normal or abnormal? It's obviously abnormal. All QRS are very tall, big.
Tall PQ on the RS.
So whenever you see a very tall QRS, what you should immediately look for? What your eye should immediately go? Standardization. Very good. Standardization is normal here, isn't it?
Normal.
10 millimeter standardization only. So this QRS is really tall. Really tall. Not artificially made tall. It is really tall. Very good. So when you have such tall TVs, what is your reference?
Ventricular enlargement.
Chamber enlargement. Very good. Ventricular enlargement is a possibility. Okay, very good. Excellent. Super. I'm very happy. Concentrate here.
Is ST elevation in one
ST elevation.
Very good. Very good.
ST
Very
elevation.
significant ST elevation. No, it is staring. Nobody should miss this ST elevation. Everybody got it, sir?
Yes.
Everybody?
Yes.
So it's a
Yes, sir.
significant ST elevation. It is a, what is it?
Probably
It's an acute event or a chronic event?
acute event.
Acute
Did you
event.
admit the patient or not?
Admit
Yes,
the
Yes,
sir.
sir.
Admitted.
What treatment you will give him? What treatment you will give him?
Thrombolysis.
Thrombolysis. Very good. Fibrinolytic. Because
Fibrinolytic.
elevation is due to red thrombus,
Red
rich in
thrombus.
fibrin. Rich in
Yes.
fibrin. So you have to dissolve the clot by giving a fibrinolytic therapy. Right? Good.
Probably left circumflex. Sir.
Good. Good. It's a probably high lateral. This lead 1 and AVL represents the high lateral leads, probably supplied by the left circumflex artery. Excellent. Super.
There's ST depression in the lateral leads before
Super.
by vessels.
Everybody able to pick up ST depression?
ST depression in the V.
V4,
V4,
Yeah,
V5,
E4, V5, E6, everything.
V4, V5, V6.
V2,
Exactly.
When one
Which
AVM
coronary
is
artery is supplying this area?
Anterolateral.
Very good. Lateral. Okay. Which coronary artery is supplying this?
again left circumflex. Sir.
Left circumflex. So this is LAD territory. This is
LAD.
LAD territory. This is LCX territory. Right? Very good. Super. Excellent. I'm very happy. You have picked up so many things nicely. Correctly. Right. Normal ECG or abnormal ECG?
Abnormal. T wave.
abnormal.
T wave
Opposite
is
direction.
opposite to the direction of the QRS. It is an abnormal ECG. We don't know whether it is a pathology or not. We will come to that later. Right. What is this?
Bradycardia.
Bradycardia.
Prolonged QT. Sir.
Excellent. See this QT. Prolonged QT. Long QT, no? Prolonged QT syndrome.
Yes, sir.
Very good. Most probably it is due to the bradycardia. Again, we have
Yes,
to,
sir.
that is why you have to apply the QTC here. You have to look for the QTC. It looks so abnormal, but if you calculate the QTC, it may be normal also. For this rate, this QT may be acceptable. Right? Okay. Very good.
Sir, previous ECG, sir.
This one?
Sir, previous ECG,
This one?
is there an ST depression in V2, sir? Is that significant?
V2.
Last
V2.
ECG.
No.
Previous ECG, sir.
In this one?
This one, sir.
ST is almost isoelectric. We call it as isoelectric. It is on the baseline. This PR segment, the P wave, R wave, PR segment is the baseline. It is
Sir, the gray ECG, sir, the previous one. I'm seeing the pink ECG.
Yeah. Yeah. This is ST depression, definitely.
Okay, sir. Is that is significant, sir?
Yes, definitely. It is an acute event, emergency to be admitted.
Okay,
No
sir.
doubt.
Okay, sir.
Any ST depression definitely is an emergency.
Okay, sir. Okay, sir. Thank you, sir. Thank you.
Okay. This T wave, anything. It's an inversion. It's definitely an abnormal T wave, right? It is opposite to the direction of the QRS. Any disease?
There's a tall T wave in V2, V3. Sir.
You mean this?
Tall T waves.
V2 is a small gray area which is sometimes equivocal. You cannot go by that. Yes, your observation is correct. Otherwise, other T waves are normal only. Only in V2, it looks slightly abnormal. But this V2 is a transition zone. I'll tell you what transition zone is later. So, okay. So
what about an
basically,
AVR?
AVR.
What about an AVR, sir?
AVR is normal.
Always reciprocal.
It's almost isoelectric only, about less than anything more than 2 small squares elevation only, you should take it. A slight elevation, you cannot. That's called a J point elevation. You cannot take it less.
We can
pathology.
see a clear U wave. We can see a clear U wave in the net.
There is no?
U wave. U
There is
wave
a
is
small
there.
U wave. This is a U wave.
Yes, sir.
Q waves.
Small Q wave. This is the Q wave. There need not be very clear Q wave. I think I have not taught you there. There's a small R wave here. There's a small Q wave here. Q wave represents the septal activation. I think I will not have time today. I'll tell you something about it. Your observation is nice. Good. Congratulations. So this is a normal ECG only. There is no abnormality. Just because we are dealing with the disease today, it doesn't mean that I should not show a normal ECG also. It is a normal ECG. I don't see a major disease in this, right? Okay. I am very happy you could pick up most of the points very clearly. All of you could pick it up. Everyone picked up. That's the answer I want. Everyone picked up. Was there any doubt for anybody? Right. So with this, we have completed the basics, right? But this is only, we have ignited the ECG. From here only, we are going to learn ECG, and you must have a thirst to learn ECG from today, right? Thanks. Any doubts so far?
No, sir.
Okay. There are no more doubts. I think you have got the basics. We have completed the basics now. One more thing which I have not taught you is what is a normal sinus rhythm. When we deal with the next class, we will start with that first, and then we will proceed further. From next week onwards, we will go to the diseases, various diseases. We will start with the coronary disease. So the next ECG class, next 2 or 3 classes will be very important for you. Yes. Somebody had a doubt?
Sir, this QTC, I remember you saying it was 0.45 seconds.
Oh, yeah.
But is there a range or it is only that exact?
Is there? I'm sorry, I didn't hear you properly.
Is there a range, sir? Is there a
Range.
normal
That's
range?
why 0.35 to 0.45.
Okay.
0.35 to 0.45. Anything less than 0.35, we call it as a short QT. But
Okay, sir.
anything more than 0.45 is a long QT, but anything more than 0.50 is definitely pathological.
Okay.
Is 0.45 to 50 is a gray area, slightly.
Okay.
Sometimes some people will normally have it also. It's a gray area. Okay. One important thing I wish to tell you. Tomorrow, the first lecture is going to be by Dr. Chenniyappan sir. No, don't miss his class. Don't miss his class. And he's going to talk to us on hypertension in a different format. You will understand management of hypertension in a much better manner than whatever we had told you earlier. So don't miss this class. I know Chenniyappan is a great teacher, a guru for me. And just 2 days, yesterday only, I requested him if he can give the talk on hypertension. He immediately agreed. And he will come on time. Absolutely, he is known for his punctuality. He will start sharp at 8 o'clock. I would like every one of you to please join at 7:55 itself. Be ready for the class.
Okay.
Don't miss his class. It will be very informative to you. Don't miss the class, right?
Okay, sir.
Bye to you. I think attendance is small today, no? There are only 17 people who have attended today. And any doubts? Any doubts so far? If you want to learn these ECGs, we have published a book, ECG Ignited. That is why I mentioned the name ECG Ignited. We have published the book, or ECG Club has published. I have also authored some chapters in that. And it will be definitely be useful to you. If somebody is interested in buying that book, you can either tell me beforehand, I will bring the book during the next class, or if you want, we can also send you by courier. The cost of the book is 1,250. This will be exactly in tune with whatever we are talking. Whatever I am talking, I am exactly talking based on that book only. So there will be a good form of a revision for you also, right? So if anybody wants the book, tell me earlier. I'll bring the books and collect the cash from you that day on the next direct class. Okay?
Okay.
Right. By 12.
Thank you, sir.
By 12.
Thank you, sir. Good
Bye.
night,
Good
sir.
night. Good night. Good night.
Thank you, sir.
Thank
Good
you,
night.
sir.
Good night, sir.
Thank you, sir.
Bye. Good night.